Hello and welcome to the UVA Medical Center Hour. I'm Justin Mutter, Director of the Medical Center Hour, which is a program of our Center for Health, Humanities, and Ethics here at UVA. We are delighted to offer today's event in partnership with the Diversity and Community Engagement Offices of UVA Health and the School of Medicine. And continuing education credit can be claimed for today's session. Please follow the instructions on the slides at the end of our session today in order to claim your credit. As is often the case with our Zoom webinar events, of which today is one, we do not have open Q&A in terms of opening our videos and audios, but we invite you to put your questions in the Q&A portion of the Zoom tab at the bottom of your screen, and that will be followed by our moderator when the time comes for our discussion. So it's my privilege today to introduce to the Medical Center Hour stage our moderator for today's event, Dr. Gregory Townsend. Dr. Townsend is an associate professor of medicine in the Division of Infectious Diseases and is also our UVA School of Medicine Associate Dean for Diversity and Inclusion. In his extraordinary career, Dr. Townsend has garnered numerous clinical and educational accolades and is an expert on the negative effects of bias in medical education. We have a wonderful panel of discussants for today's event, and Dr. Townsend will introduce our speaker as well as our panelists. Greg, welcome.
Thank you so much, Justin, and thank you for inviting Dr. Wispelwey to speak with us today. I am very excited for everyone to hear his thoughts and to hear about the work that he has been doing. So our guest speaker is Dr. Bram Wispelwey. He is a co-founder of Health for Palestine, a community organizing initiative in Palestinian refugee camps that seeks to maximize wellness and address health barriers. He is also an associate physician in the Division of Global Health Equity at Brigham Women's Hospital, an instructor in medicine at Harvard Medical School, and he also teaches at the Harvard T.H. Chan School of Public Health. Dr. Wispelwey received his medical degree from Ben Gurion University of the Negev, an MPH from Harvard University, and did his residency in internal medicine at Harvard's Brigham and Women's Hospital, where he was chief resident. Our first panelist with Dr. Wispelwey today, Dr. Tracy Downs. Dr. Downs is professor of urology and UVA Health Chief Diversity and Community Engagement Officer, and in January assumed the role of Senior Associate Dean for Diversity, Equity, and Inclusion within the School of Medicine. In this role, Dr. Downs has oversight of all aspects of diversity, equity, and inclusion in the School of Medicine. Dr. Downs earned his medical degree from the University of California, San Diego, completed his residency at Brigham Women's Hospital, and completed a fellowship at the University of California at San Francisco. Joining Dr. Downs on the panel, Dr. Scott Heysell. Dr. Heysell is an associate professor of medicine in the Division of Infectious Diseases and International Health here at UVA, specializing in clinical care and research related to HIV and mycobacterial diseases. He received his medical degree and master's in public health from Oregon Health Sciences University, did his residency in internal medicine at Yale, and did his infectious disease fellowship here at UVA. Finally, Dr. Sula Mazimba is an associate professor of medicine in the Division of Cardiology here at UVA, specializing in heart failure and transplant cardiology. He received his medical degree from the University of Zambia School of Medicine and his master's of public health degree from Wright State University. He completed his medical residency at the Kettering Medical Center at Wright State University, cardiology fellowship at the Kettering Medical Center, and advanced heart failure, heart transplant, and pulmonary vascular disease fellowship at the University of Alabama at Birmingham. We have a really stellar panel of speakers with us this afternoon, and I will turn things over now to Dr. Wispelwey. Dr. Wispelwey.
Thanks so much, Dr. Townsend, and to everyone here for having me on. I'm just going to share my screen. Yeah, so I'll make this brief so we have time for this fantastic panel and discussion and Q&A. But I'm really going to just tell a story here that we've been involved with at Brigham and Women's Hospital of sort of uncovering an example of institutional racism and really determining what to do about it and then what happened when we did. So I'm going to talk about this journey, a healing arc for hospital inequities. The model that we developed ultimately is Healing Arc. and really going from that position of institutional racism to reparative justice. I'm going to start this story really going back to my intern year, right, as house staff. This is a picture of our medical tower, right, and towards the top of this building is where we have our general medicine wards, Brigham and Women's Hospital. So this is where I now practice as a hospitalist. And when I was a trainee, when I was house staff, as all house staff in medicine, we rotated around the different internal medicine inpatient practices. So we had general medicine, but we also have cardiology, and we also have oncology in our institution. And what I had noticed, and what some other of my colleagues had noticed, is that that patients who were coming in with heart failure, we were taking care of heart failure patients on both services, on cardiology, on internal medicine. Didn't seem like, the same patients on both services, right? So here we have our general medicine tower, right? This is shared rooms, some, don't have specialty nurses or pharmacists or anything like that. But, over here, right, we have our cardiovascular building. You can see totally different look, really nice natural light. You have these... You have specialty trained nursing. These are single rooms. They're more comfortable. You also have better discharge planning, specialist pharmacy. But the catch is that only about 2/3 of our patients historically with heart failure end up on this cardiovascular service, right, on cardiology. The rest are seeing now hospitalists like me, about 1/3 of patients, right? There's a limited resource. But anecdotally, we're like, what? It seems like patients of color, right, our Black and brown patients are ending up much more on general medicine. So part of the decision was to start looking into that. Can we find out if this is actually the case? And, so I started doing this as my summer project as an MPH student while I was still in residency. And a lot of people were like, well, maybe that's true, right? Maybe there are differences, but does it really matter? Are the outcomes different? And I was like, well, I mean, even if that's the case, right, we don't want to segregate care. Are we really talking about separate but equal? And, but, couldn't get a lot of interest in it. But then sure enough, started looking into the literature, and it does matter for outcomes. In fact, if you look at national data, international data, and then our own hospital data, you see that, right, that being seen by a cardiologist as an inpatient with heart failure, some studies have been shown to have decreased mortality, lower readmission rates, better cardiology clinic follow-up. So it gets you in this virtuous cycle. And then sure enough, at Brigham and Women's Hospital, we found also worse follow-up rates and worse, and higher readmissions in our general medicine service versus cardiology service. So it did make a difference. So we decided to look into it. And ultimately, we ended up publishing on this about 2-3 years ago. But now I'm going to kind of take a little bit of a step back and talk about our approach. Because when you're doing, work, and there's probably many of you who have done some of this work before, but looking into racial and ethnic inequities in healthcare, it's very important the frame and the approach that you're taking. And so we wanted to make sure that we weren't adding to problems in the way we ended up analyzing our racial and ethnic health inequities in this case. And so we turned to a specific methodology, the public health critical race praxis that was developed by Chandra Ford out of UCLA and Collins Arienbua and others, which was really an approach to not only study but actually ameliorate the effects of structural and institutional racism. And it really took the key tenets and the key learnings from critical race theory, which is originally a legal body of scholarship about 45 years ago, first developed, also moved into the world of education and other critical scholarships, but then really in about 2010 in the public health realm, because we wanted to make sure we were considering race appropriately. And this is how we did it. This bottom bullet point was taken from our methods. We consider race to be a social construct that captures the impacts of racism rather than any innate biological differences, and therefore hypothesized that any differences we found in outcomes were due to structural drivers and institutional drivers, not biological causes, right? So it felt like this was the responsible way to do it. Just to kind of briefly go through some definitions, to make sure, we're all on the same page here. I always think this is important. This is a definition of racism taken from someone I'm lucky to call a friend and mentor, Dr. Kamara Jones, former past president of the American Public Health Association, Association, among many other roles, an incredible educator. Just the way she discusses racism, it's a system, right, of structuring opportunity and assigning value based on the social interpretation of how one looks. That, and these 3 points are really key. It unfairly disadvantages some individuals and communities, unfairly advantages others, and saps the strength of the whole society through the loss of human resources, right? And that's really the key point, is that nobody wins with structural racism and institutional racism, right? This is a pox on society, and it's historically derived, right? So this isn't a zero-sum game. Briefly on critical race theory, and there's a lot to say here. One thing to say that this is not is something that's being taught to children in school, right? This is a graduate level body of work, but it can also really be thought of, and these are key critical race scholars, and these quotes I think are very helpful. It's a movement and a collection of activists and scholars engaged in studying and transforming the relationship among race, racism, and power. And then Kimberly Crenshaw's quote here I think is really valuable. It's a practice. It's a way of seeing how the fiction of race, right, the social construction, has been transformed into concrete racial inequities. So this social construct and historical construct does ultimately have biological importance through racism, right? Through racism. Another way to really understand critical race theory is through key tenets. I'm not going to get into them, but I will touch on 3 here. One is that it's embedded in society. Racism, it's ordinary and it's pervasive, right? It's the rule. It's not the exception. And people of color in the United States certainly don't need this to be explained to them in terms of the experience of living in the United States. It's socially constructed. Again, I'll talk about that a little bit more. And it serves the material and psychic interests of the dominant group. We'll touch on that a little bit later when we talk about what happened when we announced our plans at the hospital. So, this term gets thrown around a lot, but what does it really mean, socially constructed, right? You really have to go deep into history here, but I really like this from anthropologist Patrick Wolf, is that races can be understood as traces of history, since racialization acts to reflect, justify, and reproduce into the present the unequal relationships engendered by historical processes of colonization and domination, right? So this is the process by which races are created. Wolf makes the point that race, groups of people weren't targeted because of being a racial group, right? That the racial groups were created in the targeting for other purposes, whether labor or land or resources, right? And this continues into the present in the way we categorize people in the U.S. So what is medicine's big racist mistake, right? That continues into the present. I think it's racial essentialism, right? So this is the belief that this socially constructed categorization reflects accurately inherent biological differences. Right? This is implicit and explicit in so much of medical education and training, actually, to this day. We see it in algorithms, race adjustments for kidney and lung function, although some of those are now starting to go away. The score for vaginal birth after cesarean delivery, many other elements, the way we learn about certain diseases and racial associations. And the temptation really is to consider or assume a biological cause for the inequities, right? This is the danger, getting at the danger of this racial essentialism. And really it's both a moral and an intellectual mistake. So if race, we talked about this, so racial essentialism attempts to utilize an oppressive socio-political fabrication of race. So race is socially constructed, but then it's being used in the medical world, in the scientific world, to understand genetic diversity and population distribution of alleles, ancestry. These are being confused and overlapped all the time, and they're simply inaccurate. Lots to discuss there, but we'll move on. What are the consequences of this mistake? Well, there's studies that have shown that racial essentialism exacerbates learners' racial prejudice and diminishes their empathy. And it not only contributes to interpersonal biases, right, in the medical system, but also these systemic racial biases, creating spurious standards of care for patients of color, delaying diagnosis, and what I'm going to talk about too, inhibiting patients' ability to access treatments and social resources, right? So there's many consequences to this mistake we're making. Part of the public health critical race praxis, to get back to our utilization for this study, right? This study, we're going to look at whether or not patients of color really were being triaged more often to general medicine than cardiology compared to white counterparts, is this fourth focus point I just want to mention is action, right? From the beginning, when we were studying this, we wanted to be able to do something about it. And I think that's key when you're studying racial inequities, is that thinking ahead and already being like, how are we going to fix this? If we're just another study that finds this, right? And there's been extensive evidence over the years, what are we going to do about it? So we looked at 10 years of data. Patients were self-referred to the ED because we know that, white patients being transferred from all over New England, in some cases all over the country, right, with preferential access to our hospital. We were just looking at what's happening right after people walk in the door to the hospital. We looked at patients who were admitted to either medicine or cardiology. We only had enough patients to analyze in the racial or ethnic groups of Black, Latinx, or white, and our primary outcome of interest was admission to cardiology. But first, what are we controlling for? I bring this up because a lot of the things we included in our multivariate model are in fact influenced directly by historical and structural racism. So we controlled for things like insurance status, English as a primary language, whether you're a Boston Metro resident, annual area deprivation index, so measures of poverty. All of these things are also influenced by racism. So in fact, what we were narrowing down to in our study was specifically the racism that was occurring after that patient walks in the door. We were controlling for the structural racist elements about access and other things that happen before they walk in. What did we find? Sure enough, 2/3 of white patients, this is the raw numbers, of heart failure patients were admitted to cardiology compared to only half of Black and Latinx, okay? So pretty extensive differences there. This is the tables from our multivariable analysis, and still held. So still admitting white patients more often to cardiology. All other things being held equal, including, diastolic heart failure, comorbidities. We controlled for all of these things. And one other, aspect of leading with this racial justice lens that we took, right, is that we were able to uncover other inequities. So you look down in this highlighted part in the bottom here in our propensity match cohorts, is that not only were Black patients and Latinx patients versus white patients less likely to get in cardiology, but also women, right? So also institutional sexism as well. Again, we looked at these other outcomes, and we saw that readmission rates, if you were admitted to cardiology, were in fact lower, again, as with prior data. And as with prior data, cardiology clinic follow-up was better if you were admitted to cardiology. So again, perpetuating these inequities and these outcome differences. So, we wanted to do a follow-up study and, just to get a little more information, because as we pulled in stakeholders, and there's a whole story here about really our organizing in the hospital that I could talk about, but as we were pulling in all the different stakeholders, the emergency medicine department, internal medicine, cardiology, there was a lot of, discussion around what was driving this. And so we did a follow-up study of emergency medicine providers to get their perceptions in as close to real time as possible after they admitted heart failure patients. And some of the things that stood out, here you see the question, did the patient or their family indicate a preference for admission location? So providers, predominantly white providers at our hospital, Brigham and Women's Hospital, perceived that white patients did push more often and harder to get into the cardiology clinic. So we don't know if patients really were doing that, if they were exhibiting their own white privilege, right? Or if the predominantly white providers were perceiving that more often and ignoring the requests, right, of patients of color. We weren't able to tease that out necessarily. And if patients did exhibit a preference, to what extent did this affect their decision, your decision, the provider's decision for location of admission? And a great extent in the case of white patients, right? Or at least some extent, the darker the green bar there, the more intensively it influenced their decision. So now you get to that point. So what are we going to do about it? How are we going to respond to this as an institution? What's the fundamental action approach that adheres to public health critical race praxis? And for the team of us working on this, we really felt like it was important to look outside of medicine. A lot of the key insights that I've learned over the years, about social medicine really come from the social sciences, anthropology, sociology, et cetera. And we wanted to really make sure that, if we were going to do something that had real institutional accountability, we wanted to be able to involve the community, that we were going to do something maybe different than a lot of the examples that we saw, which were often very, race blind or color blind, right, in their approach. And we wanted to be race conscious. We wanted to take these learnings from critical race theory that we had been developing over the years as a group. And so we turned actually to the work of a work of an economist and a folklorist who wrote a book called From Here to Equality, arguing for federal reparations from the U.S. government to the descendants of enslaved people in the United States, right? Federal reparations for histories of slavery, of Jim Crow, of ongoing structural racism to the present day. And they developed this model for how the government can do that we thought would be very useful for institutional accountability when these sorts of institutional racism examples were uncovered, right? Because this is a patient safety emergency for our patients of color, right? That they're getting unequal care. And so we really wanted to do something that really had some tangibility to it, and that included, impacted communities in the decision making. So we wrote about this. A colleague of mine who's now the first ever chief medical officer of New York City Public Health, Dr. Michelle Morse, and at the time hospitalist when we were doing this work. And we wrote about this in the Boston Review, and you can see the subline here that colorblind solutions have failed to achieve racial equity in healthcare, and we need both federal reparations and real institutional accountability. So the model that we borrowed from Darity and Mullen was this acknowledgment, redress, and closure, or ARC. So we were going to call it healing ARC for our institutional approach, and really it's a reparative justice approach to institutional racism, or an applicative justice approach. And you can break it down into these three pieces. One is you have to acknowledge it. You have to name the racism and be clear about it, and take responsibility for it, right, to the impacted communities. So that's the first piece. The second piece, redress. There's a compensatory step that needs to be taken here for communities that are harmed by institutional racism. Again, to make it clear that taking this seriously, not just to fix it, but to actually redress it. And then to get to a point of closure, working with impacted community members to say, hey, we've now developed a system that this isn't going to happen anymore. We believe it's not going to happen anymore, and we're going to monitor it, and we're going to monitor it with your oversight as impacted community members and patients. And so that was the idea. Very simple, but it could be applied to our heart failure inequity and also to other inequities in the hospital and even beyond, right? Because there needs to be this accountability mechanism. And doctors, and especially white doctors like myself who are sort of involved in this institutions and care, shouldn't be the ones deciding exactly what this looks like, right? We need to be involving impacted patients and community members directly. So just to briefly touch on what this redress component looks like, the way we're rolling it out right now, is for patients who are self-identified as Black or Latinx in our system, which is the same, I think, as yours, EPIC, who are coming in with heart failure. If the emergency provider puts in a bed request for general medicine, a best practice advisory, a clinical decision support will pop up in EPIC and say, hey, this patient's from a racial or ethnic group with historically inequitable access to cardiology service. Consider changing the admission to cardiology in less extreme census or overriding clinical reasons for GMS, right? To really get right at it in that moment, to remind them of this issue, or even teach for those who hadn't necessarily known about it beforehand. And theoretically, we think this is going to be pretty effective because actually, there's some studies showing that one of the things that white providers are particularly anxious about in the United States is being perceived as racist. So, and sort of you pop this up, sort of say, hey, we have a history of racism here. This patient should go to cardiology. And the other piece I'll just mention briefly too is what we've called community wisdom councils. So these are impacted community members, Black and brown folks from Boston who are community leaders and health activists, to meet and decide about what acknowledgement should look like. How can we do redress, correctly? What is the oversight process, and help us get to that point of closure for this specific inequity and potentially others. So we're now meeting monthly, and we had our first meeting just this past November. And hoping to build out actually a roadmap that will be utilizable sort of beyond our institution. Just going to finish up now, and I know because I want to give us all the time we have to discuss. Just to then talk a little bit about what happened when we wrote about this, right? And we were making these plans, right? There was pretty extensive backlash. It started actually on Dr. Michelle Morse's Twitter, and there was a lot of actually really extensive right-wing and white supremacist organizing on social media, then went to these various smaller right-wing outlets, and then eventually caught the attention of Fox News. And you can see the headline here, attacking our plan and mischaracterizing it in the study. And so, it went on to Tucker Carlson. It went on to catch a lot of press in right-wing media back last spring. Okay, so this was about April, late March, April. You could see how it was being framed here. Boston doctors call for racially discriminating against patients in order to promote social justice. Not my best fashion choice for that day. Now all over right-wing media. But this was how it was being framed, right? Even law enforcement today, so police publications also taking note of this, was really all over. What that meant is then we started getting attacks, and lots of attacks, personal attacks from Michelle as a Black woman, extensive racial and gendered slurs, threats, death threats called into our hospitalist office, just really an influx of from all over the country, people threatening to sue us, people threatening to kill us, people threatening the hospital. There were calls into the emergency room that people were going to shoot up the ED. There was a bomb threat called in. There was, their social media handles of the hospital were attacked, and it was pretty extensive. Even was impacting patient care for cardiology. So the question is why? This is a pretty small pilot that we're talking about doing, right? Just for heart failure, we're really talking about rolling this out for a year. We've documented these racial inequities that we're responsible for, right? We're talking about trying to correct this, do the right thing, do the just thing here. So, to me, I think the biggest part of the answer goes back almost 100 years to something W.E.B. Du Bois said, which he called the wages of whiteness. It's this unearned status and feeling of superiority that comes as a result of certain people understanding themselves as white, right? This fiction of whiteness in a society where this manufactured designation provides multiple forms of capital and privilege, right? So by directly saying, hey, the status quo in our heart failure triage and admissions has been to advantage white patients. That's wrong. We're going to change that, and we're also going to redress that for our patients of color because that's the right thing to do. But that threatens these wages of whiteness and this idea that, for some white people, right, this is their birthright to have that advantage. Another thing to talk about is that's gained a lot of steam in the last few years is this great replacement theory, which actually came from France, and it's about a decade old. And it's this idea that basically Black and brown immigrants in Europe are replacing and recolonizing native white Europeans. So this is widespread belief in France and other countries in Europe, but also in the United States now. Most prominently discussed, the main mouthpiece for this is Tucker Carlson of Fox News. He has millions of viewers a night. You can see here at the bottom, 30% of the U.S. believes that the country was divinely given to white Europeans and their descendants. And more than half of this group believes in the Great Replacement theory, right? So this psychologically kind of makes sense, right? You have Europeans come and colonize and commit genocide against indigenous people, right? And kidnap and enslave, West African people and treated as property, right? Chattel slavery, right? So then this response is that now there's this deep concern that actually Black and brown people are taking over the country, right? This is the belief system, and there's all sorts of ways that this gets fed into, and our publishing, about what we were doing at this time sort of really hit into this group that's really following this theory very closely, and that's why I think it went all over right-wing media there. But we also received a lot of support, right? And I think also, Dr. Scott Heysell and Greg Townsend here, with us today, right, wrote about this in the Richmond Times-Dispatch, and they also talked about another reason, right, white fragility, right, that the healing arc, could serve as a real example of what to do about racial inequities if we can collectively wade beyond the tears of white fragility and the very real tempest, right, the violence that comes as a result. So after all that backlash, we did start seeing some support, namely from fantastic doctors at the University of Virginia. The American Medical Association included Healing Arc in their organizational strategic plan for the next 3 years as well. But that wasn't the end of it, right? So that was last spring into the summer. And then what happened essentially was mainly around issues we won't discuss too much, won't have time, but around COVID antivirals. President Trump gave a speech, was widely televised, how white people were now going to the back of the line for COVID treatments. And this sort of reinitiated all the backlash in January, culminating in a January 2022 protest right in the front of our hospital of a group of neo-Nazis, the National Socialist Club 131, as they're known, with a banner saying Brigham and Women's Hospitals kills whites. They were passing out flyers with our faces on them, accusing us of an anti-white genocidal policy, the number of racist claims on these. Right in front, this is in broad daylight in downtown, in Boston, was on, as you can see here, was on MSNBC. But we made it clear right away, Dr. Morse and I, that we're not going to stop, right? And our hospital made it clear we're not going to stop. We're going to go forward with this work undeterred. And while this was really difficult in many ways for the hospital community, for everyone, because of all the organizing work we had done internally, really working on with all the different stakeholders to get this done. The hospital has maintained its commitment, and we have rolled out the redress component as of this past December. And I think the big lesson was, when you're committing to anti-racism, as our hospital has, the parent company, Mass General Brigham, has a campaign, tens of millions of dollars, called United Against Racism, to address, institutional racism in all of its facilities. That really, there is no way to be neutral here, right? When this kind of backlash happens, right, to really lean in and say, we are committed to this. We are committed to racial equity despite all this backlash. We also, this past February received extensive support in after, receiving all of these attacks. You can see here the president of the AMA put out a statement. But there, it's not just us, right? There was this article on NBC a couple days ago, about Aletha Maybank at the AMA. Dr. Kamara Jones is also mentioned as well, and many other, particularly Black women, who have been viciously attacked and threatened for doing racial equity work. So this is a nationwide problem right now. My longtime friend and mentor and former boss has sadly passed away, Dr. Paul Farmer, who I know some of you know on this call. His last publication while alive, a couple weeks before he passed, was defending us in this work in the Boston Globe. And so, currently where this leaves us, and this is my final slide, is that we're organizing for broader change and mechanisms of protecting and supporting one another for those who are experiencing these kinds of threats and attacks, and also expanding the work, beyond heart failure in the hospital. Where can we apply healing hour elsewhere at Brigham and Women's, and also beyond our institution. So, one of the exciting things is we've recently applied for a grant with University of Virginia, with Dr. Mazimba and Dr. Heysell and many others as well to continue to expand this work. So thanks a lot. I'll go ahead and stop there, and we can move on to the discussion portion.
Wow, thank you so much, Dr. Wispelwey. That was really fabulous and eye-opening, and in some ways disheartening. But I'm just so excited about the work that you're doing and your commitment to it. I want everybody to know in the audience that we, as touched on by Dr. Wispelwey, we are doing similar work here. Some of the folks who are on the panel are involved in this, both studying whether this is a problem that we have here as well, and also intending, if we do have a problem, to address it as they have at Brigham and Women's. So my first question for you, Dr. Wispelwey, I think that many people who would be thinking about this work would be wondering about how we move from, as you described, race-neutral policies to race-conscious approaches to reduce inequities in healthcare. How do we address the potential liabilities to remaining race-neutral and moving toward race-conscious approaches? And how do you get messages across when, you talked about the race-based algorithms? How do you get a message across when we're, on the one hand, trying to move away from racism, but not appearing as advocating reverse racism?
Yeah, this is such an important point, Dr. Townsend. Thanks so much. And I think that I'll start at that last piece you mentioned. One of the things that Mass General Brigham did recently, and Dr. Morse was deeply involved in it, was remove the race correction from our estimated glomerular filtration rate, or EGFR, for Black patients, right? And that's happened at a number of medical centers around the country. But it led to this confusion because that was kind of happening simultaneously to what we were proposing. They're like, wait a minute, so we're removing race from this algorithm, but we're considering race in our intervention on admissions. How does that fit, right? Isn't there a tension there? And it gets back to one of the things I was mentioning before, about the biological versus social construction. By assuming, right, by including race in these algorithms as if it's biologically meaningful, that's fundamentally, right, and it's based on, there's a lot of papers on this now, specifically on EGFR, which I won't get into, but it's that fundamental flaw of assuming that race has a biological import in how we practice clinical medicine, as opposed to racism, right? And so what we're doing is we're saying that, hey, we've had institutional racism that's led to this differential impact in how we're admitting patients. And just like you have to consider, you have to go to the source, right? If you're having a heart attack, you go after the clot that's causing the heart attack directly. If you're having institutional racism, you have to consider, race directly in the approach, right? And so if we have this problem, we have to be race conscious in it. So that to us was the fundamental distinction, is that, we're not talking about biologizing race. We're not talking about including race inappropriately. What we're saying is we're using race ultimately as a marker for racism, to say that, to identify the patients who have been harmed by our institution. Because that gets us to the second point, the race conscious versus race blind or race neutral. How can we do the equitable thing, right, for our patients of color without being able to really identify them and do right by them, right? And this gets to the difference between equality-based versus equity-based interventions. So the initial thought we had was, maybe we can do a checklist, or we can be even more objective. If we can just get this process more objective, then we'll root out the racism. But I think that was a mistaken idea, and we didn't go that route, because because of this pervasiveness and all the different ways it can sneak in, right? We instead of doing that, instead of being sort of race blind or race neutral or more objective, we want it to be race conscious directly and bypass all those other mechanisms where racism can creep in. So that's where that, and that's also based on the data, right? There's data that race blind interventions can actually exacerbate racial inequities. Why? Because the system is structurally racist, and so often that means there's channels that are already developed which white patients are going to be able to take advantage of better. And so if you don't take an equity approach, which means, because of histories of injustice and unfairness, it means taking a differential approach, right? Fundamentally, that's what equity means. And so that was our reasoning there for that.
Hey, thank you for that answer. It's such an important distinction, and thank you for elucidating that. I have a question from the audience again for you, Dr. Wispelwey. You talked about a lot of external backlash, but was there internal backlash from Brigham Women's Hospital?
Yeah, absolutely. This is a 5 or 6 year period, and there was a number of examples. One of the mistakes we made early on was we were doing this in the internal medicine side, and we didn't include emergency medicine right away, even though of their fundamental role in this whole process. And that led to real problems when we suddenly came forward with the data and we're like, hey, we have this issue. And they're like, why didn't you include us in the analysis? So there was interdepartmental, interdivisional issues here in terms of the way we did it. And that was a big learning point for us. And again, there was some fundamental misunderstandings about the point we just discussed. Why do we need to do this in a race conscious way? Why do we need to specifically identify Black and Latinx patients in this process? Can't we just, do something that's general? And there were legal questions there and extensive legal discussions about whether that was allowed. And I'll just say that it was determined that this is the right way to go forward because we had documented inequities. And so if we don't do something about them as an institution that receives public funding, that puts us in violation with the 1964 Civil Rights Act. And so not only is it is illegal, but in some ways, it's really mandated. If you document racial inequities, you have to do something about it, right? You can't be providing unequal care. And so, all of that took extensive discussions, communications. A lot of that was accelerated by some of the backlash in terms of just having some of these difficult conversations in such a big institution. But yes, it wasn't an easy process. It wasn't a straightforward process. It was a big learning process for everyone. We were all learning, and we were all, we all recognized that actually the whole reason this door was open to do this work this way was because, tens of millions of Americans out on the street, right, protesting, after George Floyd's murder, Breonna Taylor's, that this door was opened by this broader racial reckoning. And so, but that allowed a lot of these difficult conversations to take place.
Great, thank you. Thank you for that. I have a question for Dr. Heysell. So Scott, where do movements for racial equity in health fit within global health priorities, such as Dr. Wispelwey's work in Palestine? How does that inform this work in the US?
Yeah, thanks, Greg. And again, Bram, just a fantastic introduction to the topic, and just am so grateful to be able to help to bring some of your work here to UVA. I think it's going to be so important to try to carry this forward. So Greg, I think on the topic of global health, I mean, there's just so many similarities and ways in which we can learn from our experiences outside of the US to apply to our own US based systems that Bram is so well, I think, delineated. I'm struck, Bram, you mentioned, the sort of Paul Farmer's final endorsement was to support your work and show solidarity for your work. It's amazing to think that this is the late words of Paul Farmer, but he was kind enough here to enter in discussion with Rebecca Dillingham and Dick Grant last year at UVA's Center for Global Health Equity renaming. And I'll paraphrase, one of his often emphasized challenges to us all in global health. And he said something to the effect of, isn't Boston also on the globe? And isn't Charlottesville also on the globe? And so, I'm struck that, for instance, the pandemic that's really reminded us how interconnected we all are in our global health, and laid bare at the same time all of the racial and ethnic inequities that we've outlined here in the first half hour. Yet we've still fallen short in vaccinating the world. We've fallen short in providing outpatient treatment to those of most need, those that have been most disprivileged throughout the pandemic itself, but also historically in leading up to the pandemic. And it's even, that same sort of concern was voiced by Monica Pai and others recently in The Atlantic. And they doomed COVID-19 to become endemic. And they used that term endemic as a way of sort of providing false comfort and a description of diseases like tuberculosis, like HIV, that then become endemic for poor countries in the global South primarily, but also for endemicity in a means of not affecting a dominant majority within a country like the US, for instance. And so, I think that racism-related poor health outcomes could be considered endemic. That's the way that they've been treated, and we've created that endemicity, and we're responsible for creating that endemicity. So at the same time, endemic also means preventable. And so I have, a lot of hope and a lot of, I think, expectation that we can certainly do something about this. But the work, as I mentioned, is really arduous. And so one of the lessons that I've carried forward and have not been able to do well, but have sort of hopefully gotten better and better about this is when you think about a problem, and we think in global health with this terminology that's sort of similar to endemicity, we think of some places being a resource limited setting. And I've changed my thought process and really now try to, pick out when a resource is being prevented. It's not a limited resource necessarily. It's often being prevented for some reason. And so, so here, for instance, just to take the example of heart failure, for Black and brown people in Boston and in Charlottesville, this is a means of health that's being prevented in some ways. And so in this case, there are ways in which we can counter that health being prevented. And Bram started to outline that in the model of the healing arc. So so I'd be curious, if there is a bit of time, we can hear more about Bram, your experience in Palestine, because I think there's probably some common lessons that we can carry with facing what are frankly, oppressive, but, deeply entrenched barriers to health.
I'll just say this briefly. It's that, I think of a line from Marshall Gans, the legendary organizer, who worked with Cesar Chavez and, and many others, now teaches at the Harvard Kennedy School. He talks about when he came back to his home state of California, to work with Cesar Chavez, he talks about having now his Mississippi eyes, because he had been volunteering in the civil rights movement in Mississippi for years. And suddenly, these inequities that he had been blind to essentially growing up were now really clear. And so I think for, a little bit of what you're getting at too, Scott, and for me and Michelle. So Michelle was also a global health equity resident at Brigham and had worked in Haiti for many years, is that both Michelle and I, she's also a Black woman from Philadelphia, but both Michelle and I sort of coming back and after having spent a lot more time abroad and now spending more time in Boston, it was sort of like seeing those inequities with, for me, Palestine eyes, for Michelle, Haiti eyes, and the same light that Gans talked about as Mississippi eyes. Sort of like, that's what allowed us to notice this in the first place and to sort of be like, this shouldn't be acceptable, right? And so I think that element of our experience, elsewhere, and seeing, the extreme inequities that I saw in health as a medical student in Israel, and then working with Palestinian refugees and refugee camps, seeing those kind of inequities and understanding them, and then coming back to the United States gave me new eyes to see, to look at this problem.
Thank you. Thank you both, Scott and Bram. So this next question, actually, there's a comment really from one of our audience, and I'm going to segue from that into a question for Dr. Downs. So the comment, at UVA, we pay little, if any, attention to poor people in rural counties who have little, if any, access to primary care. There's a primary care arc waiting to be designed and engineered. So that's the comment. My question for you, Dr. Downs. How do institutions like ours prepare themselves legally, socially, morally, best to engage in equity initiatives? What lessons can we learn from Brigham Women's embracing the healing arc?
Yeah, excuse me. Thanks, Dr. Townsend, and thanks for allowing me to be a part of an amazing panel. And to Bram, thank you for your bravery, and go Brigham for all the great work that you guys are doing. This is really amazing, and it's kind of, leaders lead. And so we appreciate your leadership, and we're trying to do our part here in Charlottesville. And it's challenging, right, on so many levels. And I kind of fit it into, kind of a complex systems, and as far as these barriers to health. And so there's the internal work that we have to do in terms of building a diverse workforce who represents our communities, both urban as well as rural. So to the last comment, yes, the healthcare outcomes of all people in our Commonwealth of Virginia matters, whether you're in Appalachia or you're in Albemarle County or you're up in Northern Virginia, it really matters. And so I think trying to anticipate people think that we're pitting one another against each other, but also with the reality that opportunity is not distributed equally. And so I tie into how the office at the state level has been renamed from the Office of Diversity, Equity, and Inclusion, which was founded in 2019 here in the Commonwealth as one of the first recognized DEI offices in any state in the US, now has changed its name to the Office of Diversity, Opportunity, and Inclusion. So the equity term has been eliminated. And in my humble kind of perspective, I believe that the equity component is how you distribute opportunity, taking all of the various variables into account to hopefully have equal outcomes. And in this case, around heart failure for all of our patients, not a subset, but again, emphasis on all. So, so how we go about it and how we message it in confusing times where people easily want to label us and not allow us to actually articulate our vision or our direction is yet a never-ending challenge. And so for us here, I think in our early journey at UVA Health is thinking about it along the lines of inclusion work and wanting to make sure that we don't continue the exclusionary practices that have led to the outcomes that we've seen across heart failure, across who gets breast reconstruction, across who gets revascularization of lower extremities versus, amputation. These are not new outcomes that are subset limited to certain populations. And so we need to be smart about it in terms of training our own staff and teammates to think in an inclusive fashion, and also to make sure that we reach out to every aspect of our communities because their health and outcomes are important. And so I appreciate the lead that Bram and the Brigham has done. I appreciate Scott and Greg and Sula for your leadership in this work here at UVA. So thank you.
Thank you so much, Dr. Downs. Another question for you, Dr. Wispelwey, and this is largely revolves around the best practice advisory and the intervention that you have proposed. So, did you consider a nudge directed to providers caring for patients from historically marginalized groups? They're recommended considering a higher level of care based on risk, but without mentioning race explicitly.
Yeah, it's a great question. And actually, there's an example of this I just read about recently. It was in Stat News in a group in North Carolina for pneumonia. Actually, they had worse pneumonia outcomes for Black patients. And so they did a best practice advisory, but they didn't mention race specifically. They just, they did it only for Black patients because they were not being I guess is urgently considered for inpatient care, and so it's interesting, right? That would have been an option. We didn't really consider it in part because I think for me, and thinking about the work of Dr. Kamara Jones, it's really important, I think, to name racism and to say that this is the part of the problem here, and to really be explicit about that. I think that aspect really felt important, for us to grow as an institution, because again, this wasn't just one thing ultimately in heart failure, right? But it's experiences of also, the Black physicians at Brigham and this predominantly white institution, to speak to that point, Dr. Downs, about, diversity and inclusion. We have such a long way to go at our hospital there in terms of what the experiences are of Black physicians and retaining, Black physicians, and other staff. And so I think, the importance, we really felt like it was important to name that. And we felt like that the educational component around it and the for our whole, our departments and our group was really important. But it's possible, like, maybe it would have just as important of an impact. But I think, again, I'll just say too, like, I think on the theoretical side of the likelihood that this works, right, because we're studying it now, or we're about to start studying it, is this question of, because we get many of these best practice advisories, but what are the ones that really stick, right? And I think that, this is a very an emotive topic, right? This question of racial inequities in health. And so I think it's one that providers will also pay more attention to.
Great. Thank you. This next question, which may be the last question. We only have 4 minutes left, so be mindful of that. So Dr. Mazimba, this is for you. So how does a program targeted to reduce inequity, as has been proposed by Dr. Wispelwey, in this case for Black and Brown people, how does that improve health for everybody?
Yeah, thank you, Greg, for the opportunity. One thing I would like to re-echo is the fact that many times we like to think that equity work is zero-sum game. It's actually not a zero-sum game. It's not robbing Paul to pay Peter. It's actually advancing care, advancing good quality care. And one of the things that we know from actually published work is that there's actually body of literature that shows that when you implement anti-racist interventions in healthcare, they do have a spillover effect that everyone else, including white patients, actually do win. There are some studies in cancer care, for example, where access to cancer care for Black patients has been poor, and when they've improved access to cancer care, even white patients actually end up shortening their wait times to see patients, to see their physicians. And so it sort of expands our humanity and engages us to be more empathetic to others. And as a healthcare systems, we sort of respond more to human need. And so it improves quality of care in essence.
Great. Thank you so much, Sula. All right, the time for one last question. And I'll just throw this out to the group. We know that minorities, especially Black people, have been overrepresented in unethical research and underrepresented in clinical trials that have broad beneficial impacts, and they note the HPV trials here. Are there initiatives, or should there be, and how would this look, that bring in a larger racial consciousness to clinical research so that we know that our evidence-based practices are inclusive of diverse populations while acknowledging the historical injustice that have happened that instills fear in a lot of communities of color for medical research? And you have 1 minute to answer this question.
I'll provide one short comment. It's an excellent question, and it really ties in, I think, well to what academic medical centers could help and contribute to what is a larger problem, as discussed already. And I think part of the ways in which this could be addressed is simply to include more people of color as part of research teams and as part of leadership of research teams. And there are mechanisms in place to do so. For instance, through the National Institutes of Health, there are underrepresented minority related supplements that can be applied for grants, for instance. And UVA has many principal investigators that hold many different grants. And those can be supplemented by the inclusion of people that are traditionally underrepresented in science. And that is a very tangible example of a way in which we could, as an institution, shift and shift our priorities toward involving those underrepresented in the performance of the research itself.
Thank you, Scott. And the NIH has actually published a monograph on exactly this topic. How do you encourage the participation of underrepresented individuals in clinical research? So thank you, everybody. Fabulous panel. Thank you, Dr. Wispelwey, for joining us this afternoon. I'll turn you back over back to Justin.
Thank you. Thank you, Dr. Townsend. I want to thank everybody for attending today and participating in today's Medical Center Hour. I want to especially thank Dr. Wispelwey and Dr. Townsend and all of our panelists for this really critical conversation. And it's a conversation, as always, we invite you to continue. We've just had 1 hour, but please continue this conversation amongst colleagues and friends going forward. Next week, our Medical Center Hour is on Monday, not on Wednesday. So Monday, March 28th, we will have a hybrid event, both in person and Zoom, from noon to 1 p.m., where we will welcome distinguished guest Elizabeth Matreau for her talk, Who Tells Your Story? Using Narrative to Build Community, Define Purpose, and Foster Agency. Monday's event will be co-sponsored by the Compassionate Care Initiative of the School of Nursing and our local chapter of the Alpha Omega Alpha Society. For our local participants, we encourage you to attend in person at noon on March 28th. That'll be held in the Claude Moore Nursing Building, room 1110. That's room 1110 in the Claude Moore Nursing Building. You can join by Zoom, same link, which we will have available to those who need to join remotely. So thanks so much, everybody, again, and we look forward to seeing you all next week.
Thanks, everyone.
Thank you.